Morning.
Good morning.
Hello, good morning.
Good morning and a warm welcome to our panelists and audience.
So volume is quite low. I can't hear much of your voice.
Can you hear me now,
it's-
Doctor? Dr. Jasper, can you hear me?
I
Can
can
you
hear,
hear
but
me?
the volume is pretty low. That's all.
Priya? Priya, can you hear me?
Yes, ma'am. Please proceed.
Shall I start?
Yes, we are ready, madam. We are all ready.
Good morning and a warm welcome to our panelists and audience who have joined in for this edition of the Hindu Wellness Series webinar on Stroke, Be Fast, presented by the Kauvery Hospital. In layman's term, we understand stroke as some damage caused to the brain due to interruption in its blood supply. And that is what also makes stroke a medical emergency. If you face some kind of numbness in your face, in your arms or legs, or you face a sudden trouble in walking, speaking, or understanding, there is every possibility that you may have suffered a brain attack, which is almost like a lightning. Early treatment with medication can minimize brain damage and prevent additional strokes. To discuss more in detail on this important subject of stroke, on the eve of World Stroke Day, which is observed on October 29, we have with us today Dr. G. Jose Jasper, the head of Department of Brain and Spine Surgery, Neurology and Neuroscience at Kauvery Hospital, Trichy, a graduate of Christian Medical College, Vellore. He completed his PG and MCH in neurosurgery from Stanley Medical College in Chennai and followed it up with a super specialty course in medico-legal systems from Symbiosis University, Pune. Dr. Jasper has been instrumental in establishing the Kauvery Brain and Spine Center and also an exclusive stroke care center at the Kauvery Medical Center and Hospital, Tennur in Trichy. He has also introduced several advanced techniques in brain and spine surgery on patients in Trichy and elsewhere. Welcome, Dr. Jasper.
Thank you, madam. Thank you. Thank you very much.
Our second panelist, Dr. Sivarajan Thandishwaran, is a senior consultant in Department of Neurology and Neuroscience at the Kauvery Hospital in Chennai. With MBBS and MRCP from UK, his super specialization is in stroke medicine, neurorehabilitation, neurointensive care, internal medicine, and gerontology. Dr. Sivarajan has several publications to his credit in international journals, such as Brain and American Journal of Neuroradiology. Welcome to you, Dr. Sivarajan.
Thank you so much. Thank you.
Both Dr. Jasper and Dr. Sivarajan will share with us their brief presentations on their work, following which we'll take forward the discussion and open our question answer box for viewers to send in their queries. So first, I would like to invite Dr. Jasper, who will speak on what is stroke and its types, predisposing factors of the stroke, how to identify stroke, and how to prevent it. Welcome, Dr. Jasper.
Thank you, madam. I'll start my slide share now. Good morning, friends. I first of all like to thank Hindu for giving me this opportunity to reach out to a wide audience. So on behalf of Kauvery, thank you, madam, for this opportunity. Now, why do we celebrate or why do we have an awareness meet on every October 29? Is because people are not really aware of stroke. People are not aware that stroke can be prevented and treated if only you can identify it. So it's all about knowledge and improving awareness. This year's topic is actually minutes can save lives. It's about saving time. With time, whenever you save time, you're saving brain. Now, I would love to answer just a few small questions like this. So first is, what is a stroke? Can I identify a stroke? How can I prevent it? Is it treatable and all that? So simple answers to all these simple questions. This is a very iconic movie, The Good, the Bad, and the Ugly. Clint Eastwood, 1970s. We all know that. So everything has a good, bad, and ugly side. The good side of stroke is strokes are preventable, but for that you have to know about stroke. Newer treatment options are coming. In fact, year to year, we are seeing changes in protocols, guidelines, processes, which give you a much better outcome and results. And time saved is brain saved. Never forget this. It's always about time, 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 time. What are the bad things? 1 in 5 will suffer a stroke. That is very bad. And India is the stroke capital of the world now. First 4.5 hours of stroke are the most important. Again, like I say, treatment is time bound. There is always a deadline which cannot be changed. And 1/3 of all strokes occur before 40 years of age. And the very bad thing is 80% of us do not know how to identify a stroke. So which is the ugly side of stroke? 210 patients are getting a stroke in India every hour. This statistics is only for India. So 210 patients get a stroke every hour, out of which 80 actually die in India. And even among the remaining, very few come back to normal day-to-day life, functional recovery. Most of them are bedridden with the long-term where morbidity is very high. Emotional and financial cost for the family and for the nation is very high. So in simple words, what is a stroke? We all know what is a heart attack. So if there is a block to the blood vessel in the heart stops working. That is a heart attack. The same thing happens to the brain. So when the blood flow to the brain is affected, we call it as a stroke or brain attack, or in Tamil, like we say, pakavadam, or in India, simple, like we say, paralysis. So all these are literally similar terms for the same disease. So stroke is nothing but brain attack. And we have to remember that the same blood vessel which supplies the heart also supplies the brain. So if you have a heart attack, high risk of getting a stroke. And if you have a stroke, high risk of getting a heart attack. Now the types of stroke, two main types. Either the blood vessel is blocked like this, or there is a rupture of the blood vessel. So you can have a bleed or a block. 85% of all strokes are usually blocks. Now, how do you identify a stroke? This is a mnemonic you must never forget. FAST. What does FAST stand for? Look at the face of a patient who is suspected to have a stroke. You see somebody, you think they have a stroke. Look at their face. If you see an asymmetry, then you know that there is a facial weakness on one side and that patient is suffering from a stroke. If you then you look at their arm, you ask them to lift up both their arms. If there is weakness in one arm, again, you know it is a stroke that is happening. So you look at their face for asymmetry, look at their arm for weakness, and check their speech. If there is slurring of speech, incoherent speech, not able to speak, then it's a stroke. Now, what you have to remember is this is a very simple test that can be done by anybody. You don't need a degree in science to do this. So you just have to look at the face, you have to look at the arm, and you have to look at their speech. So if there is problem in even one of this, then you actually look at the time, because like I already told you, time is important. So face, arm, speech test is the most important test you have to know. Now, do all the patients who get a stroke have a stroke out of the blue, or do you have warning signs? In fact, they found that almost 40 to 70% of the patients can have a warning stroke before they have a major stroke. So a mini stroke or a warning stroke is a temporary stroke, but with complete recovery. Usually when the patient wakes up in the morning, he can have a mild problem with his speech or minimal changes in his hands, a small sensory change or a mild weakness. And we think maybe our pillow was not set right, we are not lying down in the right side. So you really do not bother, because you improve over a period of 10 to 15 minutes or less than an hour. So we do not bother about it. But these things cannot be taken lightly. If there is anything suggestive of a mini stroke, definitely the patient needs a careful evaluation by somebody who's trained in evaluating stroke, like a neurologist, to prevent a major stroke. Now, risk factors, I'll ask Dr. Sivarajan to actually start talking about the risk factor. Dr. Sivarajan, over to you.
Thank you, Dr. Jasper. There was a wonderful introduction to stroke and the various types. And as you rightly said, time is the most important essence in getting a stroke identified and getting the treatment initiated. So coming to risk factors, we often divide them as modifiable risk factors and non-modifiable risk factors. So modifiable ones are sedentary lifestyle, and nowadays we see quite a lot of youngsters who work in IT industry who sit for long hours coming with strokes. Blood pressure is something we can easily control, but poorly controlled in general across the globe. Smoking excessively and being overweight or not controlling their sugars are also common modifiable risk factors. High cholesterol, heart disease, and if it is looked after properly with the help of cardiologists to screen for atrial fibrillation and valvular heart problems, and also any dilated cardiomyopathy, when the heart chambers dilate post multiple events in the heart, those episodes can cause increased clot generation in the chambers, and that can be easily prevented by taking appropriate medicines like blood thinners. And alcohol abuse increases premature aging of blood pipes, and that can lead to blocks in the arteries and lead to strokes. And some factors are not modifiable. Example, aging is a common risk factor for stroke. As we age, the blood vessels lose their tensility and they can get a little stiffer. And as race and ethnicity in general, South Asians and the sub-Saharan Africa and those who have poor socioeconomic conditions are noted to have high risk factors for stroke, mainly due to change in lifestyle, poor food choices, and so on. There are tiny minority of patients who may have genetic risk factors, which can be identified and corrected. And coming to treatment, and we divide the treatment into hyperacute and also late acute and rehabilitation parts. In hyperacute care, it depends upon the stroke that we come across. So 80% strokes are due to clots in the blood vessels, otherwise called ischemic strokes. And within ischemic strokes, we divide them into large artery strokes and small artery strokes. Large artery strokes, there are a lot of treatments available. And the whole thing about stroke care is centered around comprehensive stroke center. So without a proper streamlined comprehensive stroke center, one cannot deliver a proper stroke care. And a comprehensive stroke center should involve facilities including CT, MR, cath lab for urgent angio and thrombectomy procedures, and post-op care in neuro ICU with the help of trained neuro staff and neuro intensivists, and 24/7 availability of expert neurosurgeons and neurologists to identify the stroke and treat them promptly, and obviously rehabilitation to improve the after effects of stroke, which includes psychologists, physiotherapists, occupational therapists, and physiatrists. So in hyperacute treatment, we obviously divide it into, as I said, ischemic or hemorrhagic. In ischemic stroke, there's a clot or there's a block in the blood vessel. And the famous drug that's revolutionized stroke since the 1995s, following the major trial that looked at clot buster medicine using alteplase. And of late, we are also using another medicine called tenecteplase. What it does is it busts the clot, and we commonly call that as a clot buster. But this drug can only be used in the first 4.5 hours. And this is a very crucial time point in the stroke treatment. The 4.5 hours starts as soon as the stroke is identified. In some patients, almost about 10 to 15% of patients wake up with a stroke. In those times, we cannot identify the onset. And we have multimodal imaging facilities like perfusion scans, MRI scans to roughly identify metabolic signatures in the scan and still choose patients. But what I want to emphasize is if the medicine is given in the first hour compared to the last 4.5 hours, the outcomes are much, much better. So what the medicine does is it cuts the fibrin strands and the platelets are released and the clot is lysed. And the medicine can only be given in the first 4.5 hours. And there are some patients we can still use up to extended time periods in large artery strokes. And beyond if when we use the drug a little later, the complication rates are high, and that can only be done in a proper setup, like a comprehensive stroke setup with the help of intensivists and neurosurgeons and so on, and all the other facilities. So some strokes, especially the large artery strokes, the clots simply don't lyse. And in fact, in about 20% of strokes in the carotid arteries, they are always very large and harder. And in this sort of scenarios, we have to go with a catheter in the cath lab and do what we call as an intra-arterial thrombectomy. And at sometimes we may have to leave a stent in the carotids when there is a thick clot, thick atheromatous plaque. And again, this procedure also is time bound, which is about 8 hours. Maybe in posterior circulation strokes like basilar artery strokes, we may extend the time window. And this is one of the most recent advancements in stroke management, which is revolutionizing our ability to help stroke patients. So as you can see in this picture, the catheter is associated with the stent, and the stent expands around the clot, and the clot is caught within the stent, and it's simply pulled back out. And the whole thing is done in a non-invasive way through a groin puncture. You don't need to subject the patient to quite long hours of anesthetics. And in selected patients, we may even go up to 24 hours. And the outcomes are much, much better. And with the availability of more specialists in this area, we're able to help a lot of patients nowadays. Even though the clots are only about 7-8 millimeter, they can block a major artery to the brain. And as we know, a tiny block can end life. So each and every stroke is unique. And in this nice picture, you can see with the arrow on the left, the flow is very limited, and the stent is seen within the blood tree, the arterial tree. And as soon as the clot is removed, you can see the river of life, which is going to perfuse the brain, and the person would recover from a heavy, dense paralysis. So some strokes are not ischemic, and they are due to bleed in the brain. And hemorrhagic strokes are often devastating strokes. And I would invite Dr. Jose Jasper to elaborate on surgical management in stroke, as he's a very experienced neurosurgeon.
Thank you, sir. Thank you. Now, surgical management of stroke, we divide it basically into two. One would be prophylactic or preventive, where you can do a surgery to prevent a stroke which is yet to come. And the other is doing emergency life-saving surgeries, rarely needed. Maybe out of every 100 patients, we end up operating on 5 to 6 or 7 or 8 patients. So emergency surgery is one, and prophylactic or preventive surgery is another. Now, when I talk of preventive surgery, what we do is, we all know the simple fact that blood flows from the heart to the brain, and obviously it has to cross the neck. So that gives you a very easy window where we can access the blood vessel going to the brain by means of a simple Doppler test. A Doppler is nothing but an ultrasound-like machine. You just see where there's a flow across the blood vessel taking blood to the brain. If there is a block in that, this can easily be found out by a Doppler, which is a non-invasive test. So if there's a block in that, then we can definitely do something, either operate, or like already Dr. Sivarajan said, we can place a stent also for carotid blocks. So this is a small example. This is a CT angiogram done. We can see that there is a small block there. There's a straight line. If you look at it, the thick blood vessel shows you the flow of blood, and there is a small block there. 80% stenosis in this patient. And what we do is we open up the blood vessel, remove the block, and the flow comes back to normal. So this is known as carotid endarterectomy. A similar procedure is available in endovascular suite also, where they call it as carotid artery stenting. Now, the decision on whether to operate or place a stent is taken up by a team made up of neurologists, neurosurgeons, and interventional team, because the right decision must be given to that particular patient. So it's a very patient-specific mode of treatment. And then I said, going on to the emergency surgeries, this is quite commonly done a malignant infarct decompression. What we told you is 80% of all strokes is usually because of block of blood vessel to the brain. Now, what happens when the blood flow is cut off? The brain starts, undergoing necrosis. Basically, it starts breaking down, and when it breaks down, it starts secreting all your harmful chemicals, which increases the pressure inside the brain. And when pressure increases inside the brain, even the normal brain cannot work. It slowly starts worsening. At one point, the pressure becomes too high. We end up losing the patient. So there, what we do is we open up the skull and free the brain so that the pressures can be brought down to normal. So this is the life-saving surgery. Rarely, if done at the right time and if the brain is not too badly involved, patient can expect functional recovery. But more than functional recovery, this is a life-saving surgery. And like sir said, if the patient comes with a bleed, then most of the time you have to go and remove the bleed, because the bleed itself again will be compressing the brain. The brain is very, very sensitive. It cannot, really deal with any rise in pressure and all that. So you have to remove the bleed and come out. In this patient, the bleed, we found out there was a small rupture in the blood vessel, which is why we have put a small metal clip. I'm sure you're able to see something inside there in the brain, one white color thing. That is a metal clip that has been put in. This is another place where surgery is always done as an emergency. Again, here, aneurysm is nothing but abnormal dilatation of the blood vessel. So the blood vessel becomes thinned out like a balloon and ruptures. The most important thing is always a history of the patient. Most of the patients will say they had a sudden onset of severe headache, very, very severe headache associated with neck pain and neck stiffness. So if they have something like this, we do a CT scan brain, and if the CT scan shows blood like this, we do a angio. When you do an angio, you find out whether there's aneurysm, and if there is aneurysm, again, the team decides that this patient will benefit from a surgery and clipping of the aneurysm, or interventional procedure with coiling of the aneurysm. Now, in India, almost 95 to 97% of the aneurysms that we see are ruptured aneurysms. In fact, if you can pick up aneurysm before it ruptures, then results can be extremely good. And quite a few of the countries abroad actually specialize in picking up aneurysms before they rupture. For example, places like Japan. Now, this is just to show you a small example of aneurysm. You can see a blood vessel which is bleeding into the brain. That is the aneurysm. It is dilated like a balloon. It is weakened and it is actually ruptured into the brain. This is to show you the clipping of the aneurysm. This is a open surgical procedure wherein we take out the aneurysm out of the circulation by putting highly specific, titanium clips inside. Now, after talking about all this, I think the most important message for the population would be about how to prevent a stroke. And I think that is where Dr. Sivarajan can again throw some light. Dr. Sivarajan, your.
Thank you, sir. So it's a beautiful description of surgical management. And as we all know, aneurysmal strokes are the most devastating strokes, and almost 1/4 of patients do not survive reaching the hospital. And with the prompt treatment, with the expert hands of neurosurgeons, a lot of lives can be saved in aneurysmal strokes. When we come to prevention of stroke, and obviously, as we said earlier, the modifiable risk factors, being active, at least walking for 20 minutes a day or 150 minutes per week is very important, because we all know sitting is the new smoking, and people should get out of their positions in their chairs in their office. At least every 20 minutes, they should walk about for 2 to 3 minutes and then come back to the chair. And I always say that you should get up and walk your stairs or go out to the sunlight and come back and do some maybe isometric neck exercises if you're an IT professional, and then come back to your chair. And this can really prevent a lot of strokes. Walking up and down stairs. Even some of my colleagues do wall push-ups, squats in between the clinics. So everybody can do a certain amount of activity in between. So this is a very nice slide showing simple stretches at office. 10 to 20 seconds of arm stretches, side stretches, and shoulder rotation, neck and finger stretches. It can be done where someone is sitting. As you can see in number 10, there's a very good description of how to look after your low back. And again, apart from increasing atherosclerotic risk and increasing obesity and cholesterol and sugars, it also increases risk of neck and back pains. So all of this can be easily avoided. So squatting involves a lot of muscle stretches in the lower and also increases the core strength. It is also a good exercise for the heart and increases the cardiac conditioning. Walking in between your working at least 15 minutes during your work time. And in elderly, at least 30 minutes of walking every day is very important. Up and down stairs, you can see, going back to our olden days as kids, so you can see, again, walking up and down stairs also improves your back strength and improves your cardiac fitness. So these are simple descriptions of wall push-ups. It can be done wherever we are, be it workspace or at home. So coming to controllable risk factors, unfortunately, we have this saying of 1/3 in blood pressure management. Almost 1/3 of public do not know that they have hypertension. And even if people who are known to have hypertension, 1/3 of them do not know their targets and they don't treat it correctly. So we prefer it to be less than 130/90, and it has to be checked periodically. And home blood pressure check and the sugar checks are actually very crucial, and rather than leaving to the last minute. And keeping your sugars less than 130 before food and less than 180 after food are the usually advised targets. And if you're a diabetic, keeping your HbA1c less than 7 is the ideal target. With diabetes, we should also regularly check your kidneys for proteinuria and creatinine levels, eyes for retinopathic changes, and also your heart to look for any modifiable changes in the heart, which may lead on to, sugars can lead on to silent coronary artery disease, and almost 1/4 of patients with diabetes do not feel any pain during heart attacks. And please avoid added sugars on table with your tea, coffee, and so on. Stop smoking and also stop alcohol. These are the worst habits which has gripped our population nowadays, and especially alcohol is something that induces a lot of strokes in youngsters that we see quite frequently. And smoking again causes stiffening of the arteries and easily causes what Dr. Jose Jasper showed, the carotid stenosis is commonly provoked by smoking, and smokers tend to develop this at a very early age. So stress is a very common factor in increasing lifestyle problems, sugar levels and hypertension, and also stroke incidence is higher in high stressful work environments and those who have extreme stress at home. So we have to limit our stress, take adequate rest, and we have to sleep adequately, which is very, very important, at least 8 hours a day, 6 hours to the minimum at least. Meditation and indulging in hobbies, which makes you meet your friends and interact with multiple individuals is also very important. So there are a lot of things we would like people to check, especially your heart. The heart undergoes changes as we age in terms of valve changes in the mitral valves, aortic valves, and also rhythm changes. Atrial fibrillation is a very common risk factor beyond 60 years of age, and almost 10 to 15% of individuals above 80 will have atrial fibrillation. And this is the most devastating risk factor to have a stroke because the clots due to atrial fibrillation are quite stronger and longer and causes a very large strokes. High cholesterol is easily modifiable. There are some families which has high triglycerides, and these families have premature heart attacks and strokes. Keeping your weight under control is very, very important. We should limit carbohydrate use and eat plenty of protein. limit fat intake to the max. High fiber is very important. Salt and sugar should be kept to a minimum. With our fast-paced culture, biryani, parotas, and cool drinks are used at a very, every street has got 4 or 5 biryani outlets. And that is one of the commonest reasons for high incidence of heart attacks and strokes. The maida-based food has got high incidence of cancer also. So we should avoid and restrict use of such food. So as Dr. Jose may also agree with me, routine health checkups has got pluses and minuses, but when we come to stroke, we insist, especially in a country like India, where there is high incidence of genetic as well as lifestyle risk factor, we should have a targeted health checkup and always be in touch with your family physician to make sure your BP, your sugars, and your family doctor hopefully will have a better idea of the whole family tree. And coming to stroke-specific checkups, we would recommend in high-risk patients to have a carotid Doppler, especially if you had multiple risk factors like hypertension, diabetes, or if you have been a smoker in the past. Please always ask for a carotid Doppler, which is not routinely part of any master health check workup. So carotid Doppler is a very simple tool, a non-invasive scan, which can pick up any blocks in the carotids. Homocysteine is something we see quite often. High levels can induce easy clotability, and simply checking your B12 and folic acid levels and replacing these two vitamins can reduce your homocysteine levels. And especially if you're a vegan or vegetarian, you have to check your homocysteine levels, because the risk of B12 and folic acid deficiency is higher in vegetarian population. In some patients, we may suggest CT scans or MRI scans along with blood vessel imaging, especially if you have had a family history of strokes or a genetic thrombophilia conditions, or if there has been a family history of aneurysmal or polycystic kidney in the family. I would ask Dr. Jose to summarize what we have discussed and tell us about the carry home message. Thank you, Dr. Jose.
Thank you, sir. I think the main idea of this October 29th is to make sure people become aware about stroke. And with awareness, with knowledge comes power over our own body, and that is when we can start preventing stroke. So the carry-home message is 80% of all strokes are preventable and treatable, because the predisposing cause most of the time is uncontrolled diabetes, hypertension, junk food, sedentary lifestyle, and all that. So all those are things that we can easily treat. And as individuals, we must know our risk factors. If I am obese, I must know my risk factors. If I'm an hypertensive, I must know my numbers. What is my BP? What is my cholesterol? We must know this. So only if you know your risk factors, you can take time to deal with it. And we have to know the early signs of stroke. Important thing is, not only must we know the signs of stroke, but our friends, our colleagues, our work spot people, our family, our neighbors must also know, because anyone can get a stroke. Like we told you in the beginning, out of every 5, 1 will get a stroke. So if 1 in 5 gets a stroke, somebody has to identify it. 4.5 hours is the magic period. With signs, lots of times we can take up the treatment window to 8 to 12 hours, and very rarely, I think Dr. Sivarajan will be able to tell you that we have gone up even to 18 to 24 hours, or more than that in selected patients. But this 4.5 hours is the standard against which all stroke treatment must be measured. And if you know stroke, you can treat stroke, you can prevent stroke. I think that is the message we would like to give the people, that stroke is knowable, treatable, and preventable. Thank you. I think with this, we'll hand over to the Hindu team. Thank you.
Thank you. Thank you for your wonderful talks.
Yeah, thank you both Dr. Jose and Dr. Sivarajan. It was really a wonderful presentation and so comprehensive, and Very, very informative. So I would still like to go back from where we started, because I feel, as you yourself pointed out, there is a lack of knowledge and awareness. And at the cost of being a little repetitive, I think we have to drive home the positive message of controlling or preventing stroke, not controlling. So one is that very basic statistics that you have shared, they're pretty scary. And you also mentioned that stroke is, India is the capital stroke, which is with many other diseases. It's not just stroke. We also hear diabetes, capital, this capital. So why do you think so? What is it with Indians, or what is it with India that we are becoming fast, capital for so many ailments, keeping in mind stroke?
So the first thing is our population, and also, there's been adoption of a lot of Western culture in our society, and there's been pressure amongst sort of friends and relatives to adopt a certain lifestyles, which increases. So if you go back a few years, we were more of agrarian society, and most of us were much fitter. There were less mechanized transport. We were walking or cycling longer distances, and now all of us are sitting most of the time, and we have work which are more stressful and demands a lot of our time away from our own personal health. And as a society, we have to change. And again, our food choices have changed dramatically compared to what our traditional food were in the past. And what do you think, Dr. Jose? You want to add?
I think Sir has covered most of it. Another main thing is, in India, somehow we refuse to take responsibility for our health or for our decisions. We believe a lot in karma. We believe the other person must do more than we can really do. Our expectation is always like that. We do not want to get up and walk. We do not want to make wise choices about our food. All those are reasons. And like you said, all preventable problems, India is the capital. We are the world capital for accidents. You know that. We are the world capital for diabetes. We are the world capital for strokes. All this need just a little effort from the side of the individual to prevent a massive, incident.
Right. I think that's very, very important. Listening to your presentation, one positive thing which I felt was you said the golden time, that period is 4.5 hours in case of a brain attack. In heart attack, we have always heard it is the first hour, 1 hour golden attack. So since it gives us that margin of time span, I think we again need to tell people that how important it is to identify the symptoms of stroke. So two little things I would like to ask you is, when we identify the symptoms first, how do we take the patient? Because when we take a heart patient, there are certain rules, how do we take them in the ambulance, or the patient should be lying down with neck up. But when we are able to identify the symptoms of stroke, is there any particular way that followed to take a patient to the hospital?
Rajan, yeah.
So the most common question I get asked in our sort of interaction with public as well as amongst colleague forums is what first aid can we give? And in heart attack, we always say, please give aspirin and a statin, and then try and get that. But unfortunately, in stroke, we should not give aspirin without having a brain scan check. Because if it is a bleeding stroke, the aspirin can make the bleed worse. So the best thing is to call an ambulance and come to a stroke-ready hospital. That's the key word. Not every hospital is stroke-ready. And quite often, what people do is they go to the nearest clinic or a emergency facility which may not have any scan facility. So that eats away your golden hour. So by the time you reach there and somebody checks you and then they refer you to a place where there is a scan, the golden hour is lost. So the first and foremost thing is to know in your locality which are all the stroke-ready hospitals, which has got all the facilities to treat emergency strokes. And I would recommend people to come in an ambulance. So for example, if somebody had a heavy weakness, in the process of transferring them into a car or a public transport or auto, they can damage the joints. They can dislocate hip and shoulders. because you wouldn't know how to handle them. And sometimes patients may have threatened airway, and they may have an additional complication from the heart, or they may choke in their own saliva or vomit that may be happening. So it is always wiser to get an expert medical personnel to be with you when you are en route. And most of an ambulance crew will know which are all the stroke-ready hospitals, and they will direct you to the nearest place.
That was very valuable input, because also we find that a lot of symptoms that you've mentioned are overlapping with multiple diseases. And so I wanted you to tell what would be the specific, very, very specific stroke related symptom. Is it that facial asymmetry, or is it something else? Because, as you said, that if we are feeling our limbs are feeling weak, we may think, okay, we lifted something heavy the previous day and that's why we are feeling a pain or something like that. So how to kind of, segregate the symptoms and be able to understand, no, this is serious and I must rush.
So
it would be a very, very stroke specific, because there are a lot of overlapping symptoms.
So if you look at our brain, a lot of our brain concentrates its surface area for hand activity, the face and speech. So that's why the acronym FAST has got face, arm, and speech. So if someone has a stroke, at least one of the three will be affected. So anyone who's got a sudden difficulty with holding their pen, or if it is a heavy weakness, a profound weakness, it is pretty obvious. The patients who don't come to our attention are those who have subtle weakness, mild difficulty in mixing their food or holding a pen, or they may have had a transient speech difficulty, and they will have thought like, oh, I just had a memory lapse, or they may have woken up with a slight numbness or tingling in the arm, and they would have thought it may be a neck sprain and so on. But when they come to us, sometimes we may also get full, or we may think like it is something else, and when we do the scan, we pick up a stroke. So doctors can also miss subtle strokes, especially strokes that happen in the back of the brain, like in the visual cortex area or in the brainstem where the cerebellum is. Those patients may have dizziness and unsteadiness, which may mimic like vertigo. So what I would recommend is, if you have any symptom that is out of character, always have it checked. Don't sit on it. Especially those who have risk factors like hypertension, diabetes, those who are smoking, or if they have high alcohol indulgence. These are the patients who should be very careful about even subtle symptoms.
And if I can add to that, like you said, being very specific. In fact, we would want to be more sensitive about the symptoms than being specific. For example, when we talk of fast, they say a layperson using fast can pick up almost 80% of all strokes without a CT or MRI or a specialist neurologist advice. And this fast is only a screening tool in the sense, okay, look, I think maybe this person is having a stroke. So once they come to the hospital, the confirmation is done by the neurologist. So like Sir said, if there is any minimal weakness, rarely they can present even with, mild visual blurring that takes place, a transient visual blurring, and we think it is nothing to worry. But all those are real dangerous signs of an impending major stroke. So when we are worried, the problem is in India, lots of people consider going to the hospital, one, as a waste of time, because once you go there, you lose one of your working day literally. And second, everybody is obviously worried about cost, because abroad, your cost is taken care of in an emergency setting by the government. Here, our out-of-pocket spending is still on the higher side. So most of the people are a little worried that, okay, if I go for a basic symptom, will I be over-investigated and all those things. But I think if there is any of these symptoms which fit in with fast, a definite investigation by a trained personnel like a neurologist who's mainly dealing with stroke is very important.
So the questions have already started coming in, and I find a lot of them are very personal and specific. I'll take a few. But before we go on to that, I would like to know, you also mentioned about a stroke-ready hospital, and you mentioned about the cost factor. So if we kind of put aside the cost factor, do you think there are enough stroke-ready hospitals within the reach of our population? Even
Can
that is
I
also a contributing factor. Yeah, please go ahead.
Yeah, sorry, Dr. Surajan, I just now, in fact, stroke-ready hospitals slowly have started coming up in the government sector also for people who are really worried about cost. Yeah, like what Sir has offered, all that is coming. I think knowledge is that a stroke-ready hospital must have a neurologist, a neurosurgeon preferably, and an interventional guy who can do all the interventional procedures along with the cath lab. So if all these are there, then obviously the rest can be taken care of. And if person is very particular about cost, now even the government hospitals have started stepping up in a big way in dealing with hyperacute stroke.
So the government of India has initiated a scheme looking at trauma, stroke as the prime theme, and our premier institute, Madras Medical College, has got a government scheme where doctors from different district general hospitals are trained on giving the clotbuster medicine. And the interventional treatment is very cost intensive. The cath labs are all there, but we don't have enough interventional radiologists across the country as a whole because the training numbers are very few. But if you look at metros like Chennai or Bangalore or Coimbatore, Madurai, most places have got at least more than 3 cath labs and at least 4 or 5 comprehensive stroke care centers. And again, we also talk about hub and spoke model. A smaller hospital which has got a CT can easily treat anyone with clotbuster or even initiate neurosurgical treatment. But if it is complex for a smaller setup, they can always stabilize the patient and transfer them to a place where there's a cath lab facility. So we call this as a drip and ship model. And all of this is out in public domain, and it's already practiced in the West. But this has to percolate to every city and every second-tier city across India to get the maximal benefit to every stroke patient.
Right, I was coming to that because you did highlight in Tamil Nadu is obviously a high on medical facilities. But when we are looking at statistics on India per se, there are many states, where the medical facilities are not really so good. So, like one member of audience, Mr. Purushottam, wants you to perhaps again asking you to elaborate on the first aid for stroke before one is able to actually reach a hospital. So somebody is in UP or Bihar and has to really travel a long distance. So what would be the first aid for stroke before we are able to take a patient to the hospital?
So the first aid always starts with A, B, C, and D, and also E, F, G. So A is airway. So just make sure they have no solid contents in the mouth, and if the airway is clear, and that ensures the breathing is maintained. So that's airway. B for breathing. C is circulation. Just make sure the pulse and the blood pressure for that person is okay. In a rural area, they may not have a blood pressure machine. At least they can feel for any warmth in the peripheries. If they're feeling cold, they can cover them with blanket and make sure they are in a left lateral position. So if they are left in a bed leaning to the left side, if the risk after stroke is in a large stroke, I'm talking about, is choking on their own saliva and so on. In a minor stroke, if they're mobile, they can be easily transported to the nearest stroke facility. A, B, C, D is for ensuring they don't get into any disability or damage due to mobilization. And always we say, don't ever forget glucose, E, F, G. G is for glucose. The commonest mimic for stroke is low sugars. And about 10% of patients who come to our emergency as suspected stroke or even with seizures are simply due to low sugars. Mostly those are on medicines for diabetes. So this is the maximal first aid one can think of, especially in stroke. And always ring for the nearest facility and get an ambulance without wasting time. And as you also talked about in India, where there are less facilities, there's a lot of money and effort put behind telestroke, like telemedicine. We have a concept called telestroke, where the specialists can link up with centers in rural areas and give advice on video conferencing, how to deal with patients in the acute care as well as in the post-acute period.
So from your hospital also, you reach out to people in the interiors through telestroke.
Within Kauvery network, we do that to Sir Dr. Jose Jasper. In fact, was doing a teleconference earlier with doctors at Salem. We do it at Karaikudi, Hosur facilities and other setups. But we are open to helping other hospitals, and we do that on an informal basis to a lot of colleagues, doctors, and other smaller setups, and we give advice over the phone. We often get images over even WhatsApp messaging and tell, okay, whether this patient is ready to be thrombolized or whether we should hold off thrombolysis. Okay, post giving the clot buster, this person should be shipped to our center for thrombectomy and so on. All of this happens in our day-to-day practice. But if it is in a formalized way by the government, it will reach to a larger public.
Doctor, I would also like you to kind of underline once more, because one member wants to know the name of medicines to be given within those 4.5 hours. But it should be given under guidance, I guess, right? It should not be like, as you mentioned, that we should not give a aspirin or something.
So medicines,
could you just underline that point once again? Yeah.
Yeah. Can I? Yeah.
Yeah, please.
Medicines, normally there are only two, like sir said, one is alteplase, otherwise known as tissue plasminogen activator, and the other is tenecteplase. But both of this must be given only by a neurologist. And for the lay person, it is enough if we know that there are drugs that can unblock a clot or break down a clot. So when we go to a hospital, and within time, we can always ask the doctor, if we are in time, can we give the clot buster drug? So tenecteplase or alteplase, but it cannot be used without medical supervision at all.
Right. TV Christie wants to know whether potential heart patients are more prone to stroke.
Not all heart patients, and as heart patients are prone to develop changes within the heart's pumping facility and also in the valves, it predisposes them to have irregular rhythm. Sometimes the heart chambers, the ejection fraction, we say, be around 60%, but it drops to 40-30. The heart doesn't pump all the blood out, so it generates clots inside. So yes, a small proportion of heart patients with severe extreme forms of heart ailments can be at risk of getting strokes. And those patients can be easily helped by taking the right sort of medicines like aspirin or clopidogrel. These are simpler blood thinners. Then we have blood anticoagulants. So these thin the blood much more strongly. Only in those select few patients we advise those medicines.
So, Dr. Jose, is there any vulnerable group that is at higher risk of a stroke? Because you also mentioned that before we reach the age of 40, I think 30% of people do tend to get a stroke. So is there any kind of gender division in it, or is there kind of any age-wise category? Or for that matter, do children ever get stroke? Could you please elaborate on that?
Yeah. I think stroke, because of the huge numbers it can affect, like 1 out of every 5 can get a stroke. It can affect literally everybody. There is no one specific group of people which is totally protected from stroke. If you already have a predisposing factor like diabetes and hypertension, sedentary lifestyle, obesity, junk food, etc., definitely the chance of getting a stroke is much higher. That is one. And women can also get stroke. Before, there used to be a myth that women were totally protected from cardiac diseases and stroke. It is not true. Pediatric, we have seen stroke in very young children. The stroke there will be of slightly different cause because their alcohol and smoking and all that is not going to come in. So you have, rarer causes of stroke, but yes, it can affect children. So there is no age that is protected from stroke. There is no gender that is protected from stroke. And if the patient already has the predisposing underlying factors, then chance of stroke becomes much higher than what it was before.
So what is the reason for stroke in children?
Dr. Swaraj?
Usually it is following some infections like chickenpox, viral infections. Sometimes kids may have some, blood disorders like sickle cell. The blood gets the blood cells get a little abnormally shaped, so they can't pass through the arteries properly and they clog it up. And very rarely they may have what we call as thrombophilia conditions, like they may have easy clotting tendencies. So infections, genetic factors, and blood disorders, these are the commonest reasons for stroke in children, but they're very, very rare. Some kids may have certain liver changes like glycogen storage disorders, and they may have increased clotting tendency due to premature atherosclerosis. These are the commonest reasons in children.
And sorry, just a second. Yeah. Newborns can also get due to vitamin K deficiency. We call that as hemorrhagic disease of the newborns, quite common in India. And rarely children can be born with congenital malformations in the blood vessels of the brain. So they can have small, vascular tumors or changes in the flow patterns of the brain, which can also lead to bleed and stroke, etc. Yeah.
So at what stage does surgical intervention is required?
I'm very happy to say that most of the time, most of the patients do not need surgery. It's very important. But when surgery is needed, it is usually a life-saving surgery. Like I already told you, very rarely we do preventive surgeries where we can prevent a stroke from coming. That is especially in carotid artery disease where either surgery or stenting can be done. So that is one place where it can make a difference. And we do selected cases where if you have a block in the blood vessel inside, we can sort of do a bypass like what you do for the heart. So that can also be rarely done. These are the very rare procedures that are done to prevent a stroke. But once a patient gets a stroke and when he is fighting for his life and when medical management has already reached its limits, at that point, rarely life-saving surgeries to remove the clot, to decrease the pressure inside the brain can be needed.
Okay, I'll just like to intervene and ask the Hindu team whether the presentation made by the doctors be available to our audience later, because a couple of them have asked questions from the presentation. They may have missed out a couple of slides and they wanted the doctors to repeat like what fast means and the names of medicines again to be given under guidance. So it will be repetitive if we take it here. So Hindu team, would you like to say anything? Okay, no problem. We'll just get that checked later. Mr. Har Gopal wants to know if there is any correlation between the economic condition and a stroke. Like, is stroke the disease of the rich and the middle class, or is it a disease of the poor?
So, no, most of the lifestyle changes, the choices are prevalent in low socioeconomic group. We all know from epidemiological studies, the incidence of smoking, especially BDs, are much higher if you go to working class and unskilled laborers. So alcohol drinking or even abuse of alcohol is higher in poor socioeconomic groups, and the incidence of stroke is much higher in that particular segment of our society. As we come to middle class, obviously, those who are misinformed and those who binge drink. So in Tamil Nadu, at least, we know that people, when they go for parties, they just binge. That can cause dehydration and increase stroke risk and so on. In general, it is a very small proportion, but that sort of culture has to change. And in higher socioeconomic group, the incidence of stroke is not that high because people are well informed. They look after their risk factors very well, and they have very good rapport with their family physicians. And the incidence of stroke are higher as they age in their 70s, 80s due to long-standing changes in the arteries due to even the best controlled diabetics. You're bound to get some changes in the blood vessels, and that sort of risk factors are noticed in the other extreme. So, yes, as with any other disease like cancers.
Right, so I'll take...
Yes, madam.
No, so there was a specific question to what you just said. From 47-year-old male who has diabetes for the last 12 years. He writes that I'm taking mild medication as my fasting sugar levels have been varying between 130 and 180. But for the last 2 months, I have been feeling vibrations in the body during sleep. I also feel tremble of hands, though there is no visible shaking. I do a lot of desk work. What is your advice for me?
Okay, so this doesn't sound very specific to stroke. If he has got vibration all over the body, this is some form of a movement disorder. I would like to talk to him and ask for his family history of, the commonest movement disorder is essential tremor. And his sugars are not that well controlled. Fasting, he says, is going all the way up to 180, which is not a good number. He has to control it very well. And those with poor controlled sugars may develop neuropathy in their limbs, and that can lead to sense of tingling, numbness, and so on. So these are not very stroke specific, but more of generalized systemic changes in his body.
Right. So in case of undetected aneurysm, will physical exercise cause it to rupture?
I don't think really, not, maybe extreme stress can, but normally it does not happen that way.
Mr. Bala Surya is asking that his father's right side of body is not active enough to walk or eat or swallow food. So will physiotherapy exercise help him to recover?
So physiotherapy is very important the first 3 months after stroke. That's where the maximum recovery is seen. And the recovery is seen even up to a year with proper directed physiotherapy. But if his father has had a stroke beyond that time point, the physiotherapy will help to maintain the body posture, the arm sort of use of prevent contractures and so on. So one would not achieve great benefits beyond a year's time point. But I do see patients who continue to take on physiotherapy for years together, like 10 years, 20 years, and that it's not fully good use of money and resources. They should help, the physiotherapists can help in terms of how to make them sit in the right pose so they can have a proper sort of neck and trunk control, and they can be seated adequately to avoid contractures, avoid bed sores, and so on. That sort of benefit may be achieved at this time point.
Padma Preeti Venugopal is asking if there is any correlation between sleep jerks and stroke.
No, sleep jerks are very common. Periodic limb movements during sleep is very, very common during the sleep onset and also when we come out of sleep. And there are extreme forms of sleep movements where patients may jump out of bed and even come to harm. That's an entirely different sort of medical treatment and diagnostic sort of arm of neurology, and they are not at all related to stroke.
And what should be the periodicity of regular checkups in patients who have had ischemic attacks before?
So routinely we see our patients after discharge in the first month and every 3 months. And beyond a year, we would like to see them once in 6 months at least. And Dr. Jose, do you want to add about your surgical patients?
Normally, we prefer our patients being, regularly seen by the neurologist. So we tell our patients, we see them once or twice, like sir said. First visit is usually within 15 days. Second is 6 weeks. Third is usually 3 to 6 months. And after that, we ask the neurologist to handle the patient. And only if there's a specific indication, we usually see that. Most of the time, they do not need regular follow-up.
Doctor, you had also mentioned about temporary stroke, which you said that could be taken as a warning stroke. So what makes strokes come back? Like, why does a stroke recur?
Yes.
Ms. Hassan wants to know. Yeah.
Shall I take?
Yeah.
The almost 30% of strokes have a warning stroke. Like patients with heart attack often have angina before they attack. Same way, the TIAs, transient ischemic attacks, the temporary strokes happen as a warning. So, for example, if somebody had a had a stenosis, carotid stenosis, and as the stenosis get tighter and tighter, the turbulence can throw clots, and often they may have what we call as ocular TIA. The vision may come and go, and they may have slow flow, reduced flow, limited arm changes, speed changes. This is a warning that the stenosis or the tightness is getting more tighter. So quite often before a large stroke, the carotid stenosis causes TIAs, or transient strokes. If somebody comes to us at that time point, and if the carotid is screened, we can stop a large stroke happening. And usually those who have a carotid TIA develop a large stroke in the next 2 weeks. So we insist them to have a carotid intervention, either surgery or stenting, within the first 2 weeks itself. And some of our patients often have their surgeries in the same admission within the next 2-3 days itself. These are the areas where we can prevent a large stroke. Same way, the stroke would have been due to heart rhythm changes, and if that is picked up on an ECG, very simple tool, and that can initiating aspirin and blood thinners can prevent another stroke. So this is how the TIA. So many hospitals run TIA clinics. We do run a TIA clinic, as is run across most of the Kauvery branches. The TIA clinics are there to screen patients, identify the specific risk factors that are causing the transient strokes, and that avoids them having a larger stroke.
So the last 2 years have been all about pandemic. So have you seen any difference in stroke patterns in post-COVID patients?
So, Dr. Jose, do you want to?
Yeah, I think COVID has affected us in more than one way. We are definitely seeing more vascular events in this last 2 years. Some can be either directly or indirectly attributed to the coronavirus itself, and some can be attributed to the vaccination itself. But most of it is due to the shift in behavior patterns that happened in the last 2 years. Lots of bed rest, lots of sedentary lifestyle, working from home, poor food habits, and increased stress because there are lots of financial issues. All this, I think, put together has really changed. In fact, what we are worried is this last 2 years where children and adults have been sort of, confined to the homes, we will be seeing more and more vascular events as time goes by, because most of us have not come back to the old activity levels that we were doing before. Sir,
could you also, yeah, sorry, please go ahead.
It's okay. Please go ahead, please.
Okay, no, I just wanted to know, like, we haven't thrown light upon the rehabilitation process of stroke patients. If you could little bit tell us about that.
So the rehabilitation starts from the time someone comes to hospital with a stroke. So, for example, we insist on checking their swallow within the first 2 hours of arrival to hospital, because the commonest complication, the dangerous complication, is aspiration pneumonias post-stroke. So we screen for swallowing, and same time we screen for speech. Speech and language therapists would have seen the patient within the first 4 hours of stroke. That is as per international stroke guidelines. And we insist the patients, if they are fit to be transferred out of bed, to be transferred within the next day itself. In some patients we don't want to because of hemodynamic problems. And the physiotherapists would initiate passive and active body movements within the first day itself. And involvement of continence specialists, because 40% of stroke patients will have urinary bowel issues. And at some point within the first week, especially in a young stroke, we would involve a psychologist or a psychiatrist, because depression is a very common factor that affects rehabilitation. So rehabilitation is not just physiotherapy alone. It is a multidisciplinary effort by physiotherapists, occupational therapists, speech and language therapists, continence therapists, and also a psychologist and a psychiatrist. So all of that has to be working in tandem. So that's why you need to be in a place where there is a comprehensive stroke unit or a comprehensive stroke care facility. Without that, you would not be able to provide a proper rehabilitation. And we do still come across patients who are given bed rest These were very, very old ancient concepts. We have moved far ahead. And even in rehabilitation, things are changing extremely fast. There are a lot of newer technologies with rehabilitation. You have robotic arm rehabilitation equipments. There are robotic walking improving equipments, balance therapy equipments, and so on. There are equipments which enhance rehabilitation using functional electrical stimulation of muscle called FES. So it's a rapidly expanding field.
I'll take one last question of one of the audience who wants to know if there is a difference between a brain attack, a stroke, and seizures.
Yes, seizures are due to electrical disturbance in the brain, which are often transient. And once the seizure is over, the person would be drowsy and they will come back to the previous level of activity. But a stroke is a sudden vascular event where there is either a block or a bleed into the brain, and that leaves potentially long-term disability. And that they are approached differently and treated differently.
Right. So we are also nearing our time. And as a quick roundup, I would like both of you to give your little brief message, because we discussed this very important topic on the eve of World Stroke Day, which is October 29. So Dr. Jose and Dr. Shivarajan, if you could quickly wrap up as what would be your message to people on World Stroke Day.
My message is very, sorry. Okay, my message is very simple. No stroke to treat stroke. I think that is the message we want to get across. Now we have lots of, ways and means in which you can really read up about stroke, online, offline, etc. Read up about it, find out about it, know fast. Remember, face, arm, speech is very important. And if you know somebody is having a stroke, go to a stroke care center. Very important. So stroke is treatable, stroke is preventable, but it can be done only if you know about it. So know your enemy and deal with it. Yes. Dr. Shivarajan.
So thanks, Dr. George. So my take-home message would be to identify the nearest stroke-ready hospitals. At times of emergency, people shouldn't be scrambling to sort of find a place where they can get the best care. So, and in the West, the government has insisted on giving certificates. There are places where to treat stroke patients, they give comprehensive stroke center certifications. So that sort of mentality should come from the government, where a place can only treat patients with stroke if they are certified to treat stroke patients. So that in a way, the public also are confident in reaching the right place. So please know your stroke-ready hospitals that are nearby and approach a proper stroke-ready hospital during a stroke.
Right. So thank you, doctors. I mean, your inputs have been really very, very valuable. And the questions also our audience asked, I think it helped to kind of cover the entire subject of stroke. I thank you all for joining in for the Hindu Wellness series brought to you by Kauvery Hospital on a very important subject, stroke, on the eve of World Stroke Day. Thank you all once again. Thank you.
Thank you.
Thank you.